All right, we have 8 studies on the docket to discuss tonight. Let's just get right on in. So, first one, adverse events following cervical spine self manipulation. This is one where people will often in social media on the use and utilization of cervical spine manipulation, um, compare risk profiles, and either make blanket statements. Is it dogmatic statements, I should say, one way or the other. Never ever get anything adjusted by a pick your, least liked provider. Typically, it's chiropractors in this field, or it's God's greatest thing on this earth. And again, like everything else, the truth lies somewhere in the middle. It's not either end. It's not the thing that's going to fix all, be all, and it's also not going to be the thing that ends all. Um, so a lot of the times the reason geared more towards a practitioner. You mentioned this one wanted to take a look at the role of the person doing it themselves. You may have seen it before, that somebody takes their neck, comes here and gets it the old right there. Does that have any increased risk of patient harm, essentially? And so what they did is the people here went through a bunch of articles and case studies to be something that has enough evidence for systematic review. So what they found was after they searched the database for since its inception up to 2004, they found almost 6,000 unique articles, of which they will discuss 24 unique cases. Half of the cases that they noted that found an adverse event associated with cervical spine self-manipulation were precipitated by neck pain or stiffness, in which case they then did a cervical self-manipulation and described a sudden or immediate onset of an adverse event following that manipulation. The adverse events were classified as mild, moderate, severe, and catastrophic. So they had 4 in the mild category, 7 in the moderate, 9 in the severe, and 4 in the catastrophic. Okay. Sadly, 2 of the people that were classified in the catastrophic adverse event did pass away. But sorry about dry throat tonight. Essentially, this is showing a similar thing that has come up in other evidence when it comes to taking a look at cervical spine manipulation as a therapy. And it's that the adverse risk of harm is very, very low. So if you take a plethora of people, hundreds, thousands, millions, the most likely thing that's going to happen if there's an adverse event is going to be some sort of minor ache or pain. So that is the most common, and there is a safety profile built around manipulation as a whole and cervical spine manipulation. So I think that overall is generally and generally a safe practice. However, that does not mean it is not without its own risk. And the risk associated with cervical spine manipulation, whether it is causative, ergo the adjustment causes an issue, or correlative, where somebody who happens to have neck pain, headaches, etc., will seek out somebody for this care because it usually helps with the pain. Let's just say, for example, they're in the process already having cervical artery dissection. Like it is happening currently because that causes neck stiffness, neck pain. We know this. And then they get a cervical spine manipulation. It the cervical spine manipulation did not cause the actual cervical dissection to happen. However, there is the chance that it could have made it worse, and it does raise the incidence rates that somebody with a cervical artery dissection received a manipulation and then they had the adverse event. So it's correlated. So again, it is not without its risk that we as practitioners must give informed consent to the patients that do you absolutely need cervical spine manipulation? And it's actually why a lot of people come see me in my practice because we utilize other things like mobilization, soft tissue work, exercise, etc. If we're after it's about cervical spine manipulation, what it's good to treat, what it's not so good to treat, the safety profile, but inherent risks, even if they're low, you leave it up to the patient. If they choose not to go through with it, whatever. There's maybe only one condition that I can think of that really benefits uniquely from cervical spine manipulation at this point. There might be a few others, but again, the unique benefit of it doesn't necessarily outweigh or doesn't necessarily mean that it can't be treated in other ways almost as effectively, like cervicogenic vertigo. That is one, so long as you diagnose it right and you know it's cervicogenic vertigo. There does seem to be good resolution with cervical spine manipulation if you screen for it and pick the right patient with the condition for that treatment. But again, you can mobilize it, you can still do exercise, and you can still treat somebody with cervicogenic vertigo in an effective manner without utilizing it. So again, long story short, this study was talking about somebody self doing a manipulation, and it seems to have the same risk profile. Their conclusions are the same conclusions that I read in all the others that somehow compare cervical spine manipulation to another intervention, and that is, and I quote, with very low certainty, this practice does have the potential for serious harms, but further research is needed to describe the motivations for using this manipulation, its prevalence, incidence, adverse events, and factors predisposing it to adverse events. They also back up a few sentences. There are only a few cases of these adverse events following self manipulation to be reported. Although this practice has the potential for those serious adverse events, we did not identify evidence that such adverse events are a common phenomenon. Now, again, one last thing that I will state before I move on to the other studies is that it seems to be uniquely the case that just given the catastrophic nature of the very low risk adverse event, ergo stroke, is such a sensationalized thing that it almost gets undue mm, popularity compared to others that are accepted as normal everyday practice. I mean, there are very few people that are talking about the harms of over the counters, the amount of deaths associated with NSAIDs and aspirin, and how people pop those like nobody's business, even though they are very safe because the total amount taken versus adverse events is low. However, it does have adverse events that do lead up to and include. So again, if all things are equal, we will be open about all possible adverse events related with any intervention to all patients. And I don't think we need to be uniquely, mm, we don't need to be necessarily uniquely attacking one intervention because I think it's one of those things where for me, how do I want to phrase this? I think if you attack this type of treatment the way you do, but leave others, it shows not only a bias, but an accepted, it just, it's more of a cultural thing, what is accepted as, or what is acceptable risks, even if the results are the same way. So it's one of those things that begs the question, do we treat all things equal? Like, do we go after all treatments the same way we do with manipulation? Or is it just because it's, you know, sensational, has a lot of sound, it's on social media? Is it because of the profession that typically utilizes it? Like, either treat all things as equal or just admit why you don't. That's the thing for me. It's getting to the point where we talk about it is a little bit tiring because I see it time and time again, and nobody's talking about the other things that are out there with worse profiles, with just as bad adverse events, like the level of adverse events that you can get from these things. It's just personally very tiring. But I'm going to get on a soapbox if I don't keep going. So let's just go into this next one, which is one more adjustment study. So let's keep this one quick. Chiropractic spinal manipulative therapy versus physical therapist-led exercise and the risk of cauda equina syndrome in adults with lumbar disc herniation, stenosis, or radiculopathy. Basically, this was asking the question is, does a lumbar manipulation increase the risk of cauda equina syndrome, which is an emergency syndrome typically associated with bladder loss and saddle paresthesia? You can have other deficits with this, but that is the most not even common. It's just the one that if you hear somebody that says, I have difficulty going to the bathroom, can't control going to the bathroom, and I feel numb around where I would sit down. It's just like, hold up. You're having a lot of issues that sound like cauda equina syndrome, and that's dangerous. You need to get to the hospital now. They wanted to see basically it's almost like the lumbar version of the adverse event. Instead of stroke, you have cauda equina syndrome. So does this have a mechanism thing, or is there an increased risk, especially when compared to exercise? I'll cut to the chase. No. When compared to physical therapy, incidence rates were about the same. Um, let's find the results here. So they measured adverse events, which were or can include the actual diagnosis of cauda equina syndrome, or patients that had bladder catheterization and fecal incontinence, which were other signs that led to the diagnosis of cauda equina syndrome in these patients. So after matching over a 10-year period, there were 34,000 patients in each cohort, either chiropractic lumbar therapy and or physical therapist led rehab. Comparing the spinal manipulative therapy cohort to the PT cohort, the incidence and risk of cauda equina syndrome did not significantly differ. In fact, the risk of bladder catheterization and fecal incontinence was significantly lower in the spinal manipulative therapy cohort. Their conclusion was among adults with lumbar disc herniation, stenosis, and or radiculopathy, we did not identify an association between manipulative therapy and an increased risk of cauda equina syndrome. So again, we're adding layers to this as far as the safety profile. But we do have to understand that this is all happening after a dutiful exam, weighing the pros and cons and risks of any intervention with the patient in front of you. So long as that is happening and you're not going to some back alley getting a random crack on with somebody that you barely know, manipulation seems to be tremendously safe. Yeah, like anything else, just get it from a reputable source that knows how to do it, knows what to screen for, who is not a candidate for it and why, and is willing to give you the informed consent about, hey, here's what it does, here's the benefits I'm hoping it'll have for you, here are the risks, here's the common risk, here are the uncommons, and it's up to you if you wish to receive it. Here are the other treatments that we can do for your condition. And from there, it's pretty much just letting the patient go, yeah, it's very low. I feel good doing it. Let's do it. Great, let's do it. Or, hey, the risk is low, but there are other things that I like more. We don't have to do it. It's like, "Fine, let's do it." That's the way it should be with everything, right? Should be. All right, moving on. AC joint and SC joint. So SC joint, AC joint, injuries in contact sports, a review of conservative versus surgical treatments. Basically, especially in contact, since it is such a prone area to get injured. Do you send them to surgery? Do you care, what are the results thereof? Both will actually demonstrate efficacy between surgery and conservative care. In fact, there doesn't seem to be a difference according to the study. With conservative care, you get a couple of potential radiographic um, degeneration or lesions because you're not always affixing it right next to each other. So a radiologist will say, "Oh no, the AC joint clavicle is still elevated or there's like some sort of displacement, yada, yada, yada." However, the symptoms, pain, and function are the same. Like it didn't matter in this study. If you got conservative care, you got better. If you got surgery, you got better at roughly the same rates, which means it's really a frank discussion between your individual case. What do you want? What is the timetable? Because here's the thing, surgery, people think it's a quick fix. You're automatically going through PT, or you should be automatically going through PT for a majority of the surgeries that you're going to go to for the conditions that I discuss, which means it's not a matter of you're avoiding. physical therapy. It's just a matter of, is the surgery necessary or more beneficial in the immediate condition before going to PT? You're not getting out of it. Either you do it and you get to avoid the surgery. In this case, it looks like you can relatively safely, or do you need to go in for the surgery because there's something there like cauda equina, or you have, you know, foreign cartilage occupying the joint space that locks it where you can't let it function. Okay, get the surgery. But with SC joint and AC joint contact injuries, outside of the extremes where it's a fracture that needs a fixation, or if it's a displacement to the point where it impedes your ability to move your arm, which, yeah, then you need surgery, you can go to the conservative route, in which case I don't know why you wouldn't just do that anyway. If you're going to put in the time, effort, blood, sweat, tears, and pain of physical therapy with the injury anyway, why go through the potential risk of surgery if it's not warranted? What they showed with this study was, this way, if you go through conservative care first and your symptoms don't resolve, you still then can go in for the surgery, and that is oftentimes very successful afterward, which means all that time, effort, blood, sweat, and tears was actually prehab, making you more robust going into the surgery. And that, I'm going to infer, leads to better results. It's better for everybody. So, conservative care for the win here. Let's move on. Prospective study on the efficacy of conservative and surgical treatments for patients with templeman joint pain and placement without reduction of the actual temporomandibular joint disc, which is a unique disc between the mandible and where it locks into your skull. Surgery versus conservative care, yet again. Let's take a look. So, results. A total of 218 participants were included in the study, and the conservative treatment group and surgical treatment group included 123 individuals. Both the conservative treatment and surgical treatments resulted in a clinically important pain reduction at 12 months. There was no significant difference in the effects of conservative and surgical treatments on pain reduction. The results of symptoms are mostly in line with those of the such as pain. In elderly patients with limited mouth opening, surgical treatments demonstrated a superior restoration of mouth opening capacity compared to conservative treatments. So, very similar to what we just talked about with the SC and AC joint stuff as far as conservative versus surgical. Come down to the individual case in front of you and as far as what the patient is hoping to get out of each individual treatment. But it seems to be conservative care up to a point is the win. So we can almost infer then that so long as there is enough time and robustness of tissue for you to properly recover from the anterior displacement without reduction, conservative care will be the best option because you get to avoid a very complicated, potentially complicated surgery. Now, you will eventually hit a point, it seems, where your natural aging process reduces your ability to recover from it purely conservatively, in which case surgery will eke out an edge out as shown in this study. So, something to consider. It's also been something that we've discussed in the past about when and how we should consider joint replacements, where we may want to put it off as long as possible, but do we really want to put it off if you're 55 and you're guaranteed to get a hip replacement? Do we want to put it off until you're 70, 75? Your ability to bounce back is probably less than when you're 60. So, something to think about. Surgery is not always the answer, but with this specific pathology, as you get older, maybe that's a conversation where you're 20, 30, or 40. Hey, let's rehab it, purely rehab it. That's the only thing we need to do. If you're starting to get into the 60s and 70s, it's like, all right, you got this condition, and it may warrant a more surgical approach first to get you better results because time, recovery ability, etc., isn't as good in that group. And again, we just go by the stats. You got a better chance of getting better with surgery. Why would I hold you from it as long as it's warranted? saying that carefully, as long as it's warranted, because we still do have an epidemic where patients are jumping straight to the end of care first. Surgery should be reserved for, for those cases like this, where there is clear demonstrable benefits to the surgery over other interventions. Those other interventions should be tried first in most cases. A lot of people will jump the line, whether it's because insurance incentivizes it or the system incentivizes it. They'll then get from their general to a consult to ortho, and that ortho will then, you know, what do? They will prescribe surgery oftentimes. So they jump right to the end. It should really be the other way. It should really be there's a lot of checks and balances and things you have to do first prior to getting a surgery. You should consider conservative routes, a lot of conservative routes. And I mean, give it a fair shot, fair time. Too many people and too many insurances will say, you've got 6 to 12 visits, you have 2 to 3 months, best of luck. Really? Really? That's just setting everybody up for failure. Even if you have somebody who's extremely motivated on both ends, clinician and patient, that's a terrible setup. If you have somebody who's not motivated, even more so. But you should exhaust conservative efforts first, including but not limited to multiple practitioners, PT, chiro, nutritionist, um, GP, co-signing on certain medications if it's warranted, pharmacological approaches, things that are able to be ceased or reversed, because surgery cannot be once it happens, you really don't want it to cease because then something went wrong and you can't take it back. So again, we can do everybody, patients, conservative clinicians, and surgeons a favor if we go that route, because there's a lot of surgeons that are doing redundant surgeries that are, I don't want to ever say it's a waste of time, but you can really reserve the surgeon's education and ability for the cases that genuinely need them, and they can focus more time and effort on those cases rather than getting swamped down by a bunch of non-specific low back, non-specific pick a condition, orthotic condition pain that should really be better managed or could be better managed as a team approach in a combined interdisciplinary setting. I said my piece. Let's move on to the next one. Weight and BMI are associated with increased failure following meniscus repairs in the pediatric and adolescent populations. That's pretty much the study. They really try and subdivide it between percentiles and this and that, not really all that relevant. I will just reiterate that it's not always purely mechanistic reasons, and that people with excess BMI who are obese have altered, let's call it physiology and biochemistry as a whole. So it's really the second, a lot of the reason that they're having reduced rates of healing and impacted ability for the meniscus to repair itself in this case is because of their physiological state. It's not just, or it's not really the mechanical extra load that the body is going through. It's the metabolic load. It's the physiological load that the body is having to go through, maintaining that excess weight that is reducing the meniscus's ability to heal after repair. So that's that one. That one's easy. Clinical features and outcome predictors in benign paroxysmal positional vertigo, a primary care neurological clinic study. Um, this one is really highlighting that while dizziness is a scary thing, like it's a scary thing on all fronts. As a patient, because I've been there, it's just like, oh Lord, you think of everything. You think, all right, is it something small? It's the most common thing. So that's in your favor. However, boy, am I having a stroke? Am I having a brain bleed? Am I having a tumor? Am I having, like, your brain just goes there as a patient. Even if you know, and this study is what I'm going to reference to kind of back this up, even though you know the benign thing is the most likely thing, you're still scared. And then as the clinician, whether you're conservative care, allopathic care, it doesn't matter. Patient walks in, hey, I am dizzy. And you're like, oh boy, we have a lot of screening to do to make sure we understand what brand of dizziness this is and how to best manage it, treat it, or refer it out if necessary. Then, if somebody comes in, because it's rarely just dizziness, it's often dizziness plus pick something. I'm dizzy and headache, dizzy and nauseous with gut issues, dizzy and neck is stiff. And you're just like, great. And here I was going to have a relaxing morning or evening. Um, it's it should be scary. Like, I'm not going to take that away. Every hand should be on deck to make sure that a proper job is done for this patient population. I like the study because it backs up the fact that the benign paroxysmal positional vertigo is still among the most common reasons that somebody's going to experience dizziness in their lifetime, and it is in the name benign, and it can be treated conservatively in most cases. They subdivide this insofar as when you have benign paroxysmal positional vertigo, there's the main thought and tenet that it is the otolith crystals within your inner ear that help with balance that are getting displaced. Essentially, think of it as like a buoy on kilter where it's not giving good information to the brain, and that's why the brain then goes cattywampus and you feel dizzy. And they subdivide it insofar as where did that buoy go wrong, ergo which canal did the otolith get displaced into. And this one, it's still the most common type is posterior canal. Then they talk about horizontal or mixed types and anterior types, etc. um, but it's still one of those things where BPPV, benign paroxysmal positional vertigo, is still the most common, and a lot of the times it is still posterior, and there's still a good way to demonstrate, or there's still the intervention of the Epley maneuver that has a lot of great evidence behind it and ability to help somebody in this case. So it's scary, but the odds are in your favor. Um, the other thing that they wanted to really point out is that the subtype, so which canal it's in, really seems to be associated with symptom duration, which can aid in your ability to properly not only diagnose it, but then give them the patient the proper maneuver to try and recombobulate yourself, for lack of a better word. Let's see. Two more. We're almost done here. This one's quick. Effects of pain neuroscience education plus resistance training on pain, disability, and sensitization in women with fibromyalgia syndrome. Yeah, just do it all. Get them to resistance train, give them the education. It's the best, period. Like, it's like every other study we've done comparing these treatments. Like, just give patients education plus exercise, and they seem to do very, very well. It's why we do the things we do in the office the way we do them. It's why I built the clinic the way that I did, to give us the time to educate the patient, give them the exercises, and if they need to, literally put a training program together to do each day. Like, education plus exercise for the win. Enough said. Last study, examining relationships and differences between the calf muscles between affected and healthy lower limbs of athletes with medial tibial stress syndrome. So this one's a little bit cattywampus. They just mushed everything together here. So let me, here we go, results. Significant deficits were found in both muscle groups, the gastrocnemius and the soleus, of the affected limb with medial tibial stress syndrome, with reduced isometric strength and fewer heel rise, so going up onto your toes, repetitions. There was lower gastrocnemius strength, soleus heel rise, soleus strength, and there was a strong positive correlation that was observed between muscle strength and endurance, while higher pain intensity was negatively associated with gastrocnemia's performance. It seems that pain intensity significantly predicted gastroc strength and endurance, but not so much with soleus function. Physiotherapy duration, the number of sessions, and self-reported pain improvement were not significant factors or predictors to either soleus or gastrocnemius endurance. Only training frequency emerged as the only independent variable. Oh boy, that was a mouthful. So Long story short, if you were paying attention through all of that, really it's just going to come down to loading the bloody tissue. Medial tibial stress syndrome, we have to make sure that we differentiate that it is not a bone stress injury because that does change how we load it and what we do when. The direction is the same. It's just the matter of the dosage and timing becomes different, and you got to make sure that you include that in your differential. But so long as it's medial tibial stress syndrome, understand that somebody might be pain averse, which is what we're seeing. So there's reduced want from the calf muscles to really give an output, ergo a push off. That's going to affect somebody's gait pattern. It's going to affect somebody's gym session. But at the end of the day, it's just going to come down to appropriate load management. So me as a clinician, there are things that I can do that may make it feel better in the short term. But in reality, if we're focused on the long term, my job is really just going to be helping somebody from a dosage standpoint, picking the right loads at the right doses, so sets, reps, frequency, to get this patient to calm down the medial tibial stress syndrome and improve their ability and function and get them back to whatever it is they're doing. A lot of the times this is running. So I think they even say here, oh yeah, a conclusion. These findings underscore the importance of targeted strength and endurance interventions for both the gastroc and soleus muscles to optimize recovery, enhance load tolerance, and reduce recurrence risk. So if somebody with medial tibial stress syndrome comes into your office, you're already thinking, all right, so the gastroc and soleus on that side are probably impaired just because there's a general protective mechanism happening here. So we can actually maybe come at it and do different things for the lower limb that will improve this person's immediate functional capacity, that will lead to long-term strength gains and get them back doing what they want to do, how they do, and what they do, and reduce the recurrence rates of medial tibial stress syndrome. That's really all my job, like a good DC's job, rehab DC's job, a good PT's job, um, a good clinician's job who's handling these orthopedic, sports based, musculoskeletal based conditions. That's all our job really is. Um, so, yeah. Oh, side note on this, it doesn't. So, some people will test and isolate things like straight leg is more gastroc, short leg is more soleus. That doesn't matter as much, truly. Um, you may be biasing one of the two muscles, but they are functioning. Doesn't matter if you're bent legged or straight legged. They might feel different, but don't overthink it from, should I do this? Like, oh, I don't have access to a seated calf raise machine. What do I do? Just calf raises. Like seriously, just do calf raises. You can do things like toe lifts or tib raises if you so choose. Like there are things that we can do. You don't have to go, well, I don't have access to this machine that will isolate this exact muscle for me. So I guess I'm up, blank creek without a paddle. No, no, it is not so specifically isolating the soleus that you have to do seated calf raises. I like them. I do. I like seated calf raises, but you don't have to do them. I'm in a ramble. I'm in that mood. I'm tired. I'm hungry. I'm doing this. So I think I'm going to call it here. Thanks for sticking with me so far. You get me goofy when I do these things late at night. Until next week.